So we're talking again about prolapse. And as we said extensively in our previous videos, prolapse is a turning inside out of the vagina. The vagina, which is a long tube normally pulled up and held in place on the inside, is turned inside out because the ligaments stretch or broke, usually as a result of childbirth. That's what prolapse is. So let me just be real clear. Prolapse is a turning inside out of the vagina. Now, when we talk about different kinds of prolapse, you've heard the names: cystocele, rectocele, enterocele, uterine prolapse. So the vagina has different parts. The front part of the vagina holds up the bladder, the back part keeps the rectum in place, the top holds the uterus up and keeps the small bowels out of the way. So if the bulge in the vagina is primarily or mostly from the front wall of the vagina, which it can be, and that's what's bulging down, what's behind it? The bladder. So the bladder is falling if the front wall's falling. Bladder, cystocele, bladder falling down. That's one type. The other type is back wall, rectum part bulging outwards, rectum bulging behind the vagina, rectocele, rectum falling out. Top is falling down. If there's a uterus, it's uterine prolapse, if the uterus is sliding down. If there's no uterus and the small bowels are protruding through, that's an enterocele. Okay. The fix is still the same. It's still the vagina falling down. So you gotta go grab the vagina, find the backside of it and pull it back into place. And if you do it the gold standard way, the gold standard repair fixes cystocele, rectocele, enterocele, and uterine prolapse, and also rectocele, which I think I said. So fixing the vagina fixes prolapse. Giving it different kinds of names. Old school. Cystocele was back in the day when all we could do in the early 1900s up to the 60s is operate through the vagina because anesthesia was so scary. All you could do is fix the part that you saw bulging down. So if you saw the front wall bulging down, that was the bladder, you fix that. And then guess what happened? The back part bulged out, so you fix that. And then the top bulged, and then you try to fix that. So the seals, the enterocele, cystocele, rectocele, really harken back from a time when the only thing we knew how to fix was what we saw. Now it's not just that. We get in and we fix the vagina. And when you fix the vagina, you fix everything. Because the vagina controls everything. The other thing is fixing the prolapse. What we know to be the standard of care for repairing prolapse, I don't think there's much dispute over that now, is to get in abdominally, find the backside of the vagina where it's falling down, grab hold of it, and pull it back up into place. The way to do that, that's considered the standard of care method, is to use a graft, which is a foreign material that's attached to the front part of the vagina, where the bladder is, the cystocele. It's attached to the black part of the vagina, where the rectum is, the rectocele, and it's attached to the top of the vagina, the enterocele part. And if you take the tail, the tip of that graft, and pull it up, there's a ligament up high inside of the upper tailbone that you can attach that graft to pull everything back up in place. And that's in effect taking a flag where the rope was cut and the flag fell down, reattaching the rope to the top of the flag and pulling the flag back up. So it's not just pulling the flag up, it's actually reinforcing the flag as well. So that technique, if you do it right, and the way we do it at Pelvic Floor Institute is we address all the components, the compartments is what they're called. We can fix the cystocele, we can fix the rectocele, we can fix the apical prolapse or the enterocele, uterine prolapse, whatever, and pull everything back up into place. Now, traditional standard of care, now done mostly laparoscopically or more and more robotically of late, is to do that procedure using a synthetic material. At the Pelvic Floor Institute, we've taken that concept a little bit further using standard of care methods that developed to help treat urinary incontinence, initially treat urinary incontinence years ago. And we've evolved those techniques, or we modified those techniques to use that same graft using strong tissue from your own body to replace the graft and attach to the front and back of the vagina and pull up on the tail of it. At PFI, that's a technique that's been written about before. It's known to be effective and works. We perfected that technique and made it into a durable, long-lasting, perfect way to resuspend the vagina in cases of prolapse. We do it with a combination of robotic surgery and an abdominal incision that actually has some of the effect of a tummy tuck in it, not all of it, but some of it, to pull up on the vagina and straighten it out. And the advantage of that is we get the effect of the gold standard procedure taken up a couple of notches so that you don't have to deal with a synthetic mesh with the risks of erosion and all of those other complications. Some women just don't want mesh in them. They don't want synthetic. Polypropylene mesh is extracted from oil. Think Strait of Hormuz. Oil is distilled into a kind of plastic thread that's woven in to form a mesh that's sterilized, that's used to pull up on the vagina. It's considered safe and it's considered standard of care, and it's done. It has a low complication rate, we're told, but when it complicates, it behaves really badly, and some women just don't want mesh in them. That allows us to do a standard of care procedure that is very effective, that at the Pelvic Floor Institute we perfected. Not very many docs know how to do it well. It's complicated, so it's not straightforward. This is not your father's Oldsmobile. It's a careful technique that meticulously developed by myself and my team, done over many hundreds of times, and shown to be very effective and as durable as the synthetic.